Housekeeping announcements. We want this to be interactive, so if there's any questions, please text your questions. Text DeBakey to the number 37607, or go to pollev.com and enter the keyword DeBakey and enter your questions. So today, I'm very pleased to have with us Dr. Chiara Bucciarelli-Ducci, who really needs no introduction within the cardiovascular MRI community. She is a senior lecturer in cardiology at the University of Bristol, and she's the co-director of the Clinical and Imaging Research Center at Bristol University. Chiara is also a physician CEO of the Society of Cardiovascular Magnetic Resonance, and she's past vice president of the European Association of Cardiovascular Imaging. Chiara is not only a leader in the field of CMR, but she's also a phenomenal researcher as well, and has published over 170 peer-reviewed publications. And she was recently named the deputy editor for the European Heart Journal. So Chiara, it's a pleasure to have you with us today from the UK. And I think you're going to talk to us today about the role of cardiovascular MRI in the evaluation of patients with MINOCA, myocardial infarction with non-obstructive coronary disease. I know this is an area that you've done a fair bit of work, and this is an area that you've really helped to push uptake of this technology. So I want to turn it over to you. Please give us your insights.
Yeah, thank you so much, Dipan, for your kind introduction, and very flattered. And thank you so much for the invite to be here. Your center is one of the most renowned cardiovascular imaging center, including for cardiology, cardiovascular more broadly, but cardiac imaging as well. So I'm very honored to be part of this grand round. Also, Houston is quite close to my heart, as we discussed before, because I did come to Houston for 5 months when I was finishing medical school, and I did a short research fellowship at the Texas Heart Institute. And so it's nice to be back, a bit virtually, but hopefully in person soon as well. So delighted to be here, and we're going to discuss during this talk the role of cardiac MRI in MINOCA, myocardial infarction, and unobstructed coronary arteries. This is a clinical entity that more and more we're recognizing, and it has a clinical impact to do a cardiac MR, and I'll share why. So MINOCA is a not negligible sort of presentation that we encounter in cardiology, because up to 15% of patients with acute coronary syndrome have unobstructed coronary arteries. And it represents a clinical dilemma. How do you discharge these patients? Do you give secondary prevention? Do you not? Is it myocarditis? Is it a small infarction? Those are all important clinical questions that we are asking us each other every day, really. And the overall mortality is also not negligible. We're learning from the literature that up to 5% can die at 12 months. So in the past, we thought it was a fairly benign condition because there is no obstructive coronary artery disease, but we're learning that this is not entirely correct. And CMR is really emerging as a clinical tool, able to really help the clinician in understanding what is the final diagnosis, and therefore adapt and change management subsequently. So why CMR? Now, this audience is actually quite advanced, I guess, in their knowledge and use of cardiac MR, but perhaps with colleagues connected from elsewhere, just to recap what MRI can offer. Is a single test, but many different aspects to it, and therefore it's what we call a one-stop shop. You do one test, and you get many answers on different aspects. We do cardiac function imaging, and so we can appreciate the size and function of the left ventricle and the right ventricle quite well. This is similar to echo, which we know on few occasions is suboptimal. I mean, not many patients, but in some, particularly in the acute setting, it can be difficult to appreciate the left ventricular function. So CMR can be a nice complementary examination to perform. But most importantly and most exciting is really the non-invasive tissue characterization. So it's an opportunity with some additional pictures to understand what is happening at myocardial level and whether the dysfunction is due to an infarct or other conditions, presence and extent of myocardial fibrosis or edema, And all of this, it can be visualized quite well with the post-contrast images. After the injection of gadolinium contrast agent, you see it accumulates in the areas of damaged myocardium, and the normal myocardium will look black. So it's really very clear here to identify the infarction, identifying infarction in the anterior wall and apex. Or T2 weighted images really allow us to visualize myocardial edema, as you see here, as compared to the normal myocardium. And of course, we can elicit also inducible myocardial ischemia if needed and if indicated, and that can complement quite nicely the whole examination. All of which can happen just in the space of 1 hour, and we're learning, in fact, also to be quicker, and we can do it potentially also in half an hour, perhaps not the whole set without T2 weighted images. But certainly my center, we can discuss later, we now try to perform CMR in half an hour. So briefly, for those of you that don't know those concepts, gadolinium contrast agents are extracellular contrast agents. So when you inject it in the myocardium, excuse me, it accumulates in the extracellular space, but in a normal myocardium, the extracellular space is quite limited. So therefore, the contrast washes in and washes out. It doesn't accumulate. And when we take images of this normal myocardium, it looks black, as I've shown you earlier. And there are still some molecules of gadolinium, but those are not visible simply because the concentration is quite minimal. When you have a myocardial infarction, for example, just as one of the damages that the heart can undergo, the pathophysiological mechanism is the rupture of the membrane, and therefore this extracellular space increases. And now gadolinium can diffuse, it can accumulate more broadly. And when we take a picture of such a condition here, we see late enhancement, which is just accumulation of the contrast, as we see in this picture here. In a chronic scar, then the mechanism is quite similar. It's again increased extracellular space and rupture membrane, and myocytes are now being replaced by collagen fibers, but there's still accumulation of contrast because the extracellular space is increased. And this is, in very simply, is the mechanism really of late enhancement. But what is quite interesting with this technique, that the contrast does not distribute in a random fashion, but it follows the pathophysiology of the underlying condition. So by recuperating those pathophysiological concepts, then we can apply them in the interpretation of these late enhancement patterns. And in particular, there is a pattern that is ischemic and therefore subendocardial. Why? Because of the pathophysiology of the underlying disease. So the ischemic necrotic wavefront phenomenon starts in the subendocardium. And as the ischemic time progresses, then the damage can become transmural full thickness. And so anytime we see subendocardial transmural, this is an ischemic heart disease sort of situation. There are, of course, many other patterns, and like this one here is a mid-wall late enhancement, as you see in this drawing here, confirmed in the long axis. When we see such late enhancements, then we can be certain that this is not ischemic heart disease, and it's quite the opposite, is in this case a dilated cardiomyopathy. Now, whether it's idiopathic or post-myocarditis or post some other conditions, then it's hard to tell at this point with CMR, but ischemic and non-ischemic can be defined quite well by CMR. We also have this pattern here of mid-wall replacement fibrosis. As you see here in this particular patient with hypertrophic cardiomyopathy, late enhancement on the area of maximal hypertrophy. Or epicardial late enhancement, as you see in this case here, and this is relevant for this talk because we're going to see cases shortly. And so this is just to refresh the concepts. So mid-wall epicardial late enhancement, as you see here, is more typical of myocarditis. And subendocardial circumferential is more typical of amyloidosis, and there are layers, and the cavity is characteristically quite dark. I mean, of course, sometimes it's not so easy to interpret the images, it's not so clear-cut. We, of course, need to rely on a good image quality to be able to appreciate whether it's epicardial, mid-wall, or subendocardial. So broadly speaking, it's really ischemic and non-ischemic. That it's a major differentiation, and that's normally quite possible from the images. So I want to just show you a case because in my center, we scan every single MINOCA patients. We tend to do more as an inpatient scan, so they can be discharged with a correct diagnosis. This is a 52-year-old male with 2 hours of chest pain, no cardiac risk factors, and troponin rise, which is quite significant. Of course, things you would do, it's not an MRI, but it's an ECG. And as you see here, there are quite significant ECG changes in the infralateral wall. And a quick portable echo shows a normal function, no regional wall motion abnormalities, and not pericardial effusion. Now, the patient, of course, undergoes an angiogram, which shows unobstructed right coronary artery. The contour is very smooth, and so no obstruction, no culprit, they are visible. And the left system is also functioning normal, and the normal coronaries, no stenosis. So the question is, how do we discharge the patient at this point? Let's say we don't have an MRI. This is the dilemma I was referring to earlier. It's really flipping the coin, of course, relying on the clinical history and a few other things, but often is not so clear-cut. However, if you do an MRI, we're going to discover how this is going to make a difference. We obviously start with the cine images, long axis and short axis, and we will do what we do with the echo. We look at the global and regional wall motion, and it looks normal. There is no pericardial effusion, so we confirm the echo cardiography findings. We then scrutinize a little more the short axis. We're really trying to find if there is a regional wall motion abnormality. But I wasn't persuaded that there wasn't any really, or certainly not a gross regional wall motion abnormality. So what it follows, obviously, is tissue characterization. So we do the T2 weighted images in the long and the short axis, and you see there is high signal intensity in the mid epicardial layer of the lateral wall, confirmed also in the long axis. And we see in the late enhancement images, we see corresponding areas of late enhancement, epicardial mid-wall, confirmed in the short axis as well. So based on what we said just earlier, the pattern is ischemic or non-ischemic. This is clearly not ischemic, and in fact, this is myocarditis. So quite a straightforward patient. In fact, is an acute myocarditis because there is inflammation and edema at the lateral wall. So patient gets discharged accordingly and without secondary prevention. Second case, a 48-year-old lady with chest pain, no cardiac risk factors, so very similar to the previous patient. A troponin of 500, so also quite significantly elevated. An ECG that in this case is not particularly abnormal, I would say, and this was done without chest pain. Nevertheless, the ECG is not so informative of potentially culprit. Echocardiogram, it's also normal, no regional wall motion abnormalities, and not pericardial effusion. Angiogram shows a unobstructed left system. You see smooth coronary arteries without plaques and without any culprit that is visible, really. The left system is interesting because it's quite small and it's quite diffusely diseased, but without really culprits that could be identified. So, of course, the inclination would be to say, well, maybe it's an infarct because the RCA doesn't look entirely healthy, particularly compared to the left. But, are we making too many assumptions? Do we not? We're sure. So let's have an MRI. Because at that point, then we're given the final reassurance. Cine images, once again, and LV function is normal. So once again, confirming the echo findings, there is no regional wall motion, no pericardial effusion. Short axis is maybe a little small. But we're looking at the inferior wall particularly because that's where the right coronary artery looks not entirely normal, but I didn't see any obvious regional wall motion abnormality. However, tissue characterization, so late enhancement post-contrast, shows a small infarct in the inferior wall. It almost looks transmural, but it also looks what I call it fluffy. So this is how an acute infarct looks like. So it looks the transmural extent is overestimated because the presence of edema, most likely. In this case, they didn't do, my staff didn't do the weighted images, which sometimes happens. So I can't demonstrate for sure that there is edema there, but it looks like as if there was one. So this is then clearly an infarct, indeed in the RCA territory, and the patients get discharged with secondary prevention. So you see those two cases, they're quite similar age group, similar presentation, and yet they have something completely different. The more dramatic ECG was in the myocarditis, and this one had basically normal ECG. So it's quite unpredictable what this patient might have. This is another case in which you see quite a focal area of edema and a small scar, but in fact there are small multiple scars, and this is a patient that had a large PFO, and as you see here, demonstrated by the bubble echo. Let that play again. Sorry that the video has been recorded with audio as well. You see clearly the shunt demonstrated. So this is to say that embolic infarctions can happen due to secondary embolism. Is not necessarily plaque embolization. So we need to keep in mind and potentially do additional testing after the MRI if required, or already scrutinize for the interatrial septum during the MRI, but do this routinely, of course, takes a long time. This other case, a 40-year-old male with acute chest pain, a T-wave inversion in V2 and V6, and troponin rise, although not so dramatic as the previous cases. And this is a total normal, completely normal coronary angiography with smooth coronary arteries, the left and the right system. So again, a bit of a dilemma, but doing the MRI becomes really clear that here there is diffuse edema, not in a coronary distribution because it's in several territories, and is coupled with epicardial late enhancement, which is quite florid, almost from base to apex. So because the pattern is epicardial, this is an acute myocarditis. And so you see with MRI, it's really, really simple, and it takes really few pictures to be able to formulate a final diagnosis. Takotsubo is also part of this MINOCA presentation, and as you know, the characteristics is apical akinesia, but not just exclusively apical, can be also basal akinesia, and the area of akinesia presents extensive myocardial edema, as demonstrated by the MRI, and absence of myocardial late enhancement. And this is the imaging characteristics of Takotsubo and CMR. So these are three cases. I don't know if it projects well, but three cases that presents very differently with very different ECGs. And I think the point here is how all this information come together to make a diagnosis. 84-year-old lady with female with shortness of breath and elevated troponin and obstructed angios, and she presents with Torsad. And this is the first presentation. The second case, 24-year-old with also shortness of breath, elevated troponin, unobstructed coronaries, and LV dysfunction. And also the first case had LV dysfunction. And the third case, 46-year-old with chest pain, elevated troponin, unobstructed angio, and normal LV on echo. With this ECG. So what do we think is the worst patient? I think it would be normal to say is the first one, given the ECG presentation and given the LV dysfunction. But let's look at the MRI and see whether maybe we're going to change our mind. So the first one is presents extensive edema on the apical mid segments, confirming two views and not late enhancement. So this is a case of a Takotsubo cardiomyopathy. Second case is a patient that has also quite extensive edema and in various regions. The late enhancement looks quite aggressive in the sense that several areas are involved, in fact, most of the myocardium. And the pattern on occasion seems subendocardial, but actually there is mid-wall. And this patient finally underwent also biopsy, which I'll show you in a second. And then this other patient presents also edema and an area, very focal area of late enhancement. So the three different diagnoses here is Takotsubo, here's giant cell myocarditis, and this is a small embolic myocardial infarction. So you see among the two patients, the ECG was more malignant, let's say, in the first patient, but actually the diagnosis that it's more serious is the giant cell myocarditis, and this patient was referred to a transplant center, whereas this patient then fully recovered and got discharged. In Bristol, we've seen some of this, not so many, but few of this cardiomyopathy with Takotsubo with intense edema presenting with the malignant ECG. And therefore, we publish a small case series in which we raise the suspicion that also having intense edema might cause these electrical abnormalities that justify this ECG presentation. But it is a reversible cause, so we've been having extensive discussions with my electrophysiologist, for example, whether we should put a device in this patient in view of the ECG. And my position was that based on the MRI, this is reversible, and so we shouldn't put a device. But I know it's debated, and there is not so much data in the literature. Other interesting cases we had here in Bristol, because we scan all this MINOCA, is patients with ulcerative colitis that was admitted with bloody diarrhea and chest pain, and ECG showed inferior ST elevation, and the echo and the angiogram, which were normal, and then addressed to CMR, and we found very florid findings of myocarditis, and we put it in the context of most likely an acute autoimmune myocarditis. And when the colitis was more in remission due to the pharmacological treatment, the myocarditis also got better. So just an interesting observation how the gut can also influence the heart indirectly. Or cases of recreational drug users with all sorts of findings in cardiomyopathy. So either dilated cardiomyopathy or small focal infarction due to spasm of either the microvessels or the epicardial arteries in the presence of maybe a plaques, some plaques already. So show you all these cases now to go back to the literature and see what the literature says. Well, bright is bad. That was one of my editorial to say that, late enhancement is not just scar, it can be myocarditis, it can be replacement fibrosis. And so normally, Kim and Judd, who have been teaching MRI all over the world and to most of us, we're saying bright is dead. And so I try to rephrase that into bright is bad, just to incorporate also the non-ischemic heart disease presentations. So what does the literature say for CMR in MINOCA? Not huge amount of literature, but expanding. So this is a paper from a group in Italy, the ITAMI study. So it's the only really multi-center study on MINOCA. And they basically described the presentation, and the presentation that can have, so myocarditis, within the MINOCA presentation as a pattern which is mainly epicardial, or in the infralateral wall, or mid-wall fibrosis, mid-wall late enhancement in the septum. And those are the patterns which are mostly observed. And the pattern that has a worst pseudoprognosis is the one with the mid-wall replacement fibrosis. The group in Germany, Marold and others, have demonstrated this many years ago, but that was in a single center study, whereas this is a much larger cohort and a much more recent publication. My work in Bristol has been more pragmatic with my clinical colleagues. And what I've been doing is really recording the diagnosis before the CMR, which is what I've really shown you in those cases. And then we perform a CMR, and then we see how we change the diagnosis and how much we reclassified those patients. And to my surprise, we actually reclassified quite a few. And all the boxes in black are the patients that we reclassified. And those in white are the only diagnoses that were confirmed also by the CMR. For example, patient thought to have myocarditis was confirmed in 34 cases, but in 23, they actually have an infarction. And in 5, they had Takotsubo. Patients thought to have an MI actually had myocarditis, and some had Takotsubo. And those thought to have Takotsubo, 1 had the myocarditis and 5 had infarction. And so on, and also cardiomyopathies can be identified in the MINOCA presentation. So when we then analyzed the data further, we observed that we were able to make a new diagnosis in 25% of the patients. And that new diagnosis led also to a change in management. So up to 30% of patients had a new diagnosis with a change in management. So it was quite impactful. In other words, it's really quite a significant percentage of patients. In 34% of patients, there was no change, not in the diagnosis, not in the management. But in 12%, there was no change in the diagnosis, but there was a change in management because maybe the MRI added an additional information. For example, in the case of an infarction, there was a thrombus that the MRI identified that was not known. And so that has changed management, but not changing the diagnosis. But really, the most important number is this 29% in changing new diagnosis and changing management. Recently, there was this paper to which also Moazzam Allah from your group had participated that it was really a systematic review of the published studies in CMR and MINOCA 27, so up to 3,000 patients. And what these investigators wanted to see is whether there was any relationship between the diagnosis of myocarditis and the angio presentation. As we know, MINOCA includes both the unobstructed coronary arteries, but also those with a non-obstructive coronary artery disease, less than 50% stenosis. And so what they demonstrated, myocarditis really is more than 2 times likely if the coronary arteries are totally unobstructed, as opposed to have plaques. It's an interesting finding, so it can be intuitive, but what's nice about this publication is the fact that it's a large cohort and is kind of final demonstration of what clinically, it's a quite sound message. So with my group, we have a very large database of MINOCA, almost 900 patients collected over the years in a prospective fashion. And we published this paper on the prognosis of CMR in MINOCA, and we demonstrated that those presenting with ST elevation and with a final diagnosis of cardiomyopathy on CMR are those with the worst diagnosis. So it's not infarction because it tends to be quite small and therefore doesn't really have an impact on the prognosis. And this Italian study is also the follow-up of the ITAMI study from the same multicenter group in Italy. And what they demonstrated is the prognosis at 6 months is basically better if you have no edema, no late enhancement. And this is, I would say, quite obvious. But if you have late enhancement with edema that persists, then the survival is reduced. And so it's fairly intuitive, but it's nice to have it demonstrated properly in this JACC publication. Now, what do the guidelines say? Because that's also quite interesting, and the guidelines inform the management, and the research informs the guidelines. So to close the loop, going back to the guidelines, so the 2017 ESC STEMI guidelines, for the first time, mention MINOCA, which has been, I think, overlooked or not properly addressed in previous editions. And there wasn't enough evidence at the time to produce a class recommendation. So therefore, I was part of the panel. So what I propose to do is this figure that I think can help clinicians in deciding whether to approach MINOCA with a non-invasive approach or an invasive approach. If you decide for the more non-invasive, then of course there is an echo that you should be doing as part of clinical care. The CMR will be suggested really in all conditions to be able to identify a final diagnosis, and definitely has a role in the suspicion of myocarditis, but also in the suspicion of any cardiomyopathies with a troponin rise, but suspicion of a myocardial infarction as well. And this is the ESC STEMI guidelines 2017. Then the 4th definition of myocardial infarction 2018, and also was very privileged to be part of this writing group. And then I saw it as my role to really introduce the concept of cardiac MRI viability, but also ischemic and non-ischemic damage. And the importance of identifying these small damages, which are the reason why there are troponin rises, and therefore this really embracing this tool to try to understand a little bit more what's happening at myocardial level when we have those troponin rises. So I was very happy, to be able to include this figure in this important document. Now, recently, just a month ago, 2 months ago, the ESC published the non-STEMI guidelines. And so now for the first time, really CMR is in the class of recommendations. So it's not just the figure that I've shown you before, but now is really a class. It's a recommendation. And in patients with MINOCA, it says it is recommended to perform CMR in all MINOCA patients without an obvious underlying cause. In class 1, so it means you must do it, and well, it's good, would be good practice to do it. And level of evidence B, because of course they're not randomized trials, but now there is a wealth of evidence in favor of this. And I hope those clinical cases have persuaded you that it is indeed very important and it changes management. As I said, that changed my practice here locally, and this is also based on the request of my clinical colleagues. And so we perform CMR in every MINOCA. What do the AHA-ACC guidelines say? Well, there is this consensus scientific statement document on MINOCA, and CMR plays also quite a central role. In fact, is the only advanced imaging modality that's mentioned here, because it can identify really myocarditis, Takotsubo, and a small myocardial infarction quite well. So I think there is a agreement also in the United States, in North America, that CMR is very important. We're doing for time. So when we discuss doing CMR in every MINOCA patients, there are often colleagues that are more prone to biopsy, for example. So there is that debate, should we have an MRI, should we have a biopsy? I think my view is that in patients with normal EF, you wouldn't really want to embark in a biopsy if you can have an MRI. Patients with LV dysfunction, of course, it's a different story. And it's important to also have the histological confirmation, particularly if we think it's giant cell myocarditis. But this is work done by Eiko Marotz and other colleagues in Germany quite early, essentially confirming the late enhancement by CMR did correspond to a diagnosis of myocarditis histologically. And when you compare really CMR and biopsy to see how many diagnoses can be identified, is interesting to observe that biopsy identified many more myocarditis than MRI could. And is really the Takotsubo cardiomyopathy seen on CMR that seem to follow into the category of myocarditis by histology. So I think there is more that we probably need to learn about Takotsubo cardiomyopathy and the changes happening at myocardial level. And to conclude now, the role of CMR relaxometry and these parametric techniques, T1 and T2 mapping and ECV, do we need to do them? Is it useful? What does it add? So just to say that essentially the Society of CMR, but experts worldwide, they're increasingly using those mapping techniques to understand more about the pathophysiology of the disease and be able to identify really small changes in the myocardium. Myocarditis, and try to create almost an atlas of cardiac conditions with the different sort of parameters of T1 mapping and ECV and T2 and T2 star. Myocarditis in particular is quite typical that has a very increased T1 mapping, native T1, increased ECV, and very increased T2, particularly in the acute presentation. And so with that in mind, the Lake Louise criteria are the revised criteria to diagnose myocarditis with CMR. And it does include T2 weighted and T1 weighted, as I've shown you in my cases. Those are the tools we use for reporting those images. But now there is the addition of T2 mapping and also T1 mapping in addition as well. So this is to make the diagnosis more accurate. And there's been quite a bit of work done by several colleagues. This is work from Vanessa Ferreira in Oxford that demonstrated that we can see abnormalities in myocarditis even just with native T1 mapping, and which corresponds quite nicely to the areas of late enhancement in the post-contrast images. So this is to say that if there is a patient with renal dysfunction, which we have a reservation in giving contrast, then we can still be able to make a final diagnosis just by using native T1 and not contrast and late enhancements, therefore. So to conclude, I think the CMR really unlocks the diagnosis in MINOCA. It is a clinical dilemma. We don't know how to discharge this patient, and if we do, we're not 100% sure. We can identify the acute myocarditis, Takotsubo cardiomyopathy, can be an infarct, can be embolic, it can be spontaneous recanalization, it can be a plaque embolization. can be really multifactorial. Can be some cardiomyopathies also that we randomly discover. But it's really the best single test to make the final diagnosis. And why? Because really there's direct visualization of that damage, and therefore is relatively straightforward and easy to identify. Thank you so much for your attention, and I believe the future of cardiovascular imaging, and certainly cardiac MRI, is quite bright. I'm smiling, and this is a T2 mapping sequence, and mid-short axis, you see the papillary muscles in a pleasing distribution. So that's how I look at it. It's smiling. Thank you very much for your attention.
Great. Chiara, that was wonderful. Wonderful talk, and I love that last image of the smiley face. So let me ask you a couple questions. There's one comment from that was texted in that I just want to read out loud. Somebody says, "I'm reviewing CV imaging for my exams, and your videos are very helpful." So thank you. So I think that's wonderful. So let me. I think obviously one of the reasons that we're doing these grand rounds virtually is because we're in the middle of this pandemic from SARS-CoV-2, COVID. And we know from data on hospitalized patients with COVID that as much as 20% of these patients may have elevations in troponins and cardiac enzymes, suggesting that there is some myocardial damage that may occur. Can you share with us any experience you have or what the data is on myocardial damage with regard to COVID? Because I think in this setting, everything comes back to COVID in the end.
Yes, no, you're totally right, and totally agree. So yeah, we've been doing a few cases here in my center, but also in London, the Royal Free have decided to do cardiac MRI in spite of echo, despite the echo. So they skip the echo for social distancing, I guess, with the patient. They've been embracing MRI, replacing echo. So just to give you the extreme end of the spectrum, that's the Royal Free in London, Mariana Fontana. So she has done like something 100 COVID cases. Hospitalized. So what we see in these patients is myocarditis, indeed, and we see florid myocarditis, not dissimilar to what we're being seen here. Another pattern that I've been observing is really diffuse edema without any late enhancement. So it's either myocarditis also without late enhancement, or it can be the cytokine storms that produce all the vast inflammation that reaches the myocardium as well. So it's either direct infection of the virus in the myocardium, or is the cytokines really inflammatory cascade that can affect the heart. We also been seeing small embolic infarctions as a result of the prothrombotic state. And on occasion, there was a dual pattern. It was a myocarditis and a small embolic infarct. I mean, of course, we don't know if this patient had, this infarct and the myocarditis before, because the edema images are not always entirely clear. And so that would be the discriminator, whether it's an acute or chronic presentation. But certainly this is in the hospitalized patient. As you alluded to, I think there's been a lot of debate in the literature about the role of CMR in this asymptomatic convalescent COVID. And once there are publications out there that demonstrate interesting findings, I think we need to be a little careful and be in the safe side and kind of follow the scientific process by which certain findings, they need to be confirmed by other groups in larger cohorts. And therefore, I think we remain quite interested, but we need to watch the space. We shouldn't create too much sort of panic and agitation, so much so the patient rush, to get MRI because they had COVID 6 months ago, that kind of way. So in the UK, we are very active as a larger community. We submitted grants to the kind of NIH in the UK equivalent. And we have now 2 studies funded and recruiting. One is called COVID Heart, in which we do 2 CMRs at admission and follow-up with a number of blood and ECG biomarkers. And then there is another one called CMR, which exclusively in the convalescent COVID. And so I'm hoping that, in 1 year maximum, we're going to have very robust data to rely on.
All right. Well, that's great. That's something to stay tuned for. So let me ask you, at your center, I think you mentioned that really most of these patients that present with this myocardial infarction with non-obstructed or unobstructed coronaries, you do a CMR on them prior to discharge. Now, what would you recommend for smaller hospitals that may see these patients but they don't have access to CMR technology? We have that in the U.S. as well, where CMR is at certain large centers, but there's a lot of hospitals that these patients present to that may not have access to CMR in-house.
Yeah, well, that's an excellent point, Dipan. One of my other studies, actually I forgot to put in the slides, I just realized, is that we demonstrated that the diagnostic pickup rate of CMR and MINOCA is the highest if the MRI is done within 2 weeks. And you can still diagnose it afterwards, but edema will start to resolve and so on. So the diagnostic elements, become less, and therefore your diagnostic pickup rate can be decreased. So those hospitals, those colleagues should request an MRI in the outpatient, of course, but early outpatient, I would say, within a month would be ideal. But it's better to have it later than not having it. I think that's the other concept. So even if patients have it at 6 months, because that's what it takes, I think it's fine. If it was an infarct, it's still there. And if it was a florid myocarditis, I think there would be signs still there. However, there is no data, and I just want to say that because we have a study going on, that what's happening with the myocarditis findings chronically, does all this late enhancement resolves completely, or is there a more permanent scar? I think it's still unknown, which is why we're doing the study, because often people say, well, do I need a repeat CMR, for example? And it's unclear if they do. I mean, there needs to be a clinical reason, but simply kind of monitoring the disease with CMR, I would not necessarily recommend doing that.
Okay, great. And then, one of the things you talked about, the differential here obviously is Takotsubo's is one of the, sometimes it's myocarditis, sometimes it's Takotsubo's, sometimes it's actually an infarct. So, one of the things I've noticed is that in the literature, it seems like the incidence of Takotsubo's seems to be increasing. Now, do you think that's because of just increased recognition, or do you think something is changing, that there is actually a true underlying increase in the incidence of Takotsubo's that's occurring?
So certainly during COVID, I can tell you that we saw more Takotsubo's, and that was an interesting observation. I think probably the anxiety and the preoccupation of the pandemic had an impact, I think, on patients and mental health. In general terms, outside the COVID pandemic, I think Takotsubo is increasingly recognized. I think, and therefore they also MRI is increasingly done, and therefore then Takotsubo is finally diagnosed. I think these people in the past perhaps were just labeled with having an acute coronary syndrome, having an infarct, secondary prevention, and then magically this myocardium recuperated. So I think two answers. I think it's more CMR done and more recognized, and also there is more knowledge in the referring physicians that CMR can do it and Takotsubo exists.
All right, great. Well, wonderful. Thank you so much for beaming in. I guess it's afternoon over there in the UK right now. So, and I know you're going to meet with our fellows afterward as well for our noon conference. But this was a wonderful kind of overview of the role of CMR in evaluation of MINOCA. Thank you very much for for joining us, and we look forward to seeing you again soon. Okay.
Yeah, well, thank you so much for having me.
Okay, bye-bye.
Thank you.